Hello, thank you for joining us. We have a presentation on access to school-based behavioral health resources across the Commonwealth of Massachusetts. My name is Melissa Perot, and I'm a faculty member in school psychology at the University of Massachusetts, Boston.
My name is Sarah Whitcomb. I am an associate professor of school psychology at the University of Massachusetts in Amherst.
So we want to introduce the Birch Project. The Birch Project is behavioral health integrated resources for children. The mission is to provide professional development resources to schools and coordinate behavioral health services across schools and agencies. As we mentioned, we represent the UMass Boston and Amherst campuses, and we are sponsored by Boston Children's Hospital. The webinar today has several goals. The first one is we want to talk about the staffing rates in our Massachusetts schools, particularly as it relates to access to behavioral health services and where there are the greatest inequities. We're going to talk about the resources that are provided by the State Department of Education. Then we're going to take this information and share what we learned from our stakeholders in interviews and provide recommendations. At the bottom of this is a Google form that if you can cut and paste, it gives a place for us to get feedback from you about this webinar and these maps too, in hopes of our continued learning. So what we did is we looked at publicly available data from the Department of Education in the 2018-2019 school year. We looked at the data across 406 districts, including 291 LEAs, chartered vocational and online schools. And we took this information and combined it looking at the number of students, the percentage of economically disadvantaged students, and the number of professional support personnel. These were put into an equation looking at our professional support personnel. We included only those that are licensed professionals through the Department of Education. It includes school counselors, school social workers, school psychologists, and school nurses. Each of these credentials requires at least 60 hours of graduate training and supervised field experience. We know there are many other professionals that work in our schools and support our children's behavioral health. However, they are not the people that we did not include on this are other categories of support personnel, such as rehabilitation counselors. It does not include the staffing and educational collaboratives and more restrictive placements, such as acute residential facilities or DYS. It does not include community-based behavioral health providers through the community mental health agencies. We also did not include any schools with less than 5 students. So we took together this information and we identified that for our 951,000 students in our Commonwealth, we have over 7,000 professional support personnel. Of these personnel, 5,427 focus on behavioral health. These are our social workers, our school adjustment counselors, our school counselors, and our school psychologists. The only difference in these two numbers is that the bottom number does not specifically include school nurses. While we recognize their tremendous contributions to behavioral health, we also know that they have other responsibilities meeting the health needs of students. So when we look at this, we took this information and we looked at the different number of professionals in our schools, and then we made ratios to see how well it intersects with our understanding of access. We took this information and then compared it to the national recommendations, and here's how it looks on a graph. If you look at the number of students to school nurse, the National Association of School Nurses recommends 1 to every 750. We see that our students and all of our all the quartiles of economic need have a degree of access to school nurses that is better than the recommended national ratio. When you look at the ratio to school counselors, again, the recommendation for there is 1 to every 250. And we see that in none of our districts is there adequate access to school counselors. And our students that experience the highest economic need have the least amount of access. And our school social workers, our school adjustment counselors, the same recommendation of 1 for every 250 students is there. you see that none of our districts meet that ratio and expectation. And there is some degree of variability with our our students with the highest economic need having some decent access, and our students with the lowest economic need, our more wealthy communities, have less access to social workers. And when you look at school psychologists, you see that our recommendation is 1 to every 500 students, and our students in our highest economic need have some of the least access, with more than twice the recommended ratio of access to services.
So the next part of this project, what we did was we took the information that we had gathered and we wanted to visually be able to depict that information across the state of Massachusetts. So what you see here are the list of towns and school districts where we see the most economic need and the least amount of staff provided in those districts. And so we can see those areas of red are where we see that comparison between the kids that have the most economic needs and the fewest staff focused on behavioral health in their districts. So then we started asking more questions and wanted to see the way different resources across the state of Massachusetts are seen on maps. So we created a map where we looked at the different educational collaboratives across the state of Massachusetts. What we learned is that there are a large number of educational collaboratives. I think they're in the range of 28 to 30 collaboratives across the state. And one of the interesting facts that we learned was that almost 30% of our districts, our high needs districts as we've defined them, do not actually belong to a collaborative. So when we were trying to figure out how districts might access regional supports, thinking that collaboratives might be the structure for that to happen, we were surprised by some of the statistics and visually seeing some parts of the state where there is limited access to collaborative support. So then another question that we had is we wanted to know where various resources that are provided by our Department of Education are allotted across the state. And so DESE has a number of different types of grants. Some of them are written for district level access to services. Others are particular schools can apply for the grant funds. All of the grants that we focused on, again, had a relationship with behavioral health services. So what you're seeing here in the red, again, are our high needs districts. We've continued to show where the educational collaboratives are as well, but now layered on top are some of these district level DESE grants. So specifically, there are grants funded that are the Safe and Supportive Schools grants, and another grant that's commonly known as the 336 grant that DESE has funded the Walker School to provide some behavioral health professional development and services to districts across the state, are depicted here in green. So the school level grants that I had mentioned before are those grants that individual schools can apply for to access services. Again, we were interested in the behavioral health oriented services. So for example, schools can apply to be part of what we know as the PBIS Academy, which is part of the MTSS academies that DESE provides to learn about positive behavioral interventions and supports. These academies often come with face-to-face training opportunities as well as on-site technical assistance and consultative support. The S3 grant, and which I believe stands for Systems of Student Support, and the SEL Mental Health Academy is another academy that is offered by DESE. So those dots that you see here are the number of schools across the state who have accessed the training through these academies. And finally, what you see here are the layers of all that I've just spoken about. So we have our high need districts in red, we have our educational collaboratives in blue, we have those district level grants from DESE in green, and then we have those school level DESE grants that are the black dots. So this is sort of an aggregate picture of where the resources, particularly from DESE, are spread across the state.
So these maps provided us some really powerful information, but we found ourselves wondering, what does this all mean? What do these maps tell us? And so to get perspective, we interviewed more than 15 stakeholders. And these stakeholders worked with many different positions, including at the State Department of Education, at the Department of and at the Executive Office of Health and Human Services. We interviewed superintendents and district administrators, people in the collaboratives, school and community-based providers, and other university trainers that work in the pre-service domain. And in general, the statement that stood out the most to us is, where does this leave our districts? If we have 406 districts and these scatters of resources, how does this happen? And one quote is, access to state resources depends on having a savvy superintendent and a good grant writer. People did acknowledge that sometimes districts get more than one grant, and if they get one, they're more likely to get another one. And we are seeing districts work together in consortiums to receive these grants and grant writing support from collaboratives. But internal leadership is critical in order for schools to be able to access this. And in the summary of our findings, all the feedback from the interviews left us with these impressions. The state, and through our Department of Education in particular, there's not a cohesive plan for school-based prevention efforts. This leaves many districts trying to figure out on their own how to do this. And when there's 406, they may have some districts that are well-resourced, that have access to other resources and partnerships, but there's a lack of a cohesive plan across the state on how to do this. We also recognize that there are some limited access to behavioral services for some specific communities, and the issue of sustainability is a critical issue in that. And then we know that many of the high needs districts, roughly a third of our high needs districts, are not members of collaboratives or getting access to these resources from the state. And each of these resources also requires a district level leader that buys in and supports these efforts. And it also requires partnership and effectiveness in working with a team. We've also identified, Sarah, talk about some of your work of what you've noticed with district leaders.
Right, so I work in primarily the western part of the state, and it is, it's interesting seeing the variability from district to district in terms of how district leadership is organized, what their primary areas for focus are, as well as how they access resources, particularly resources from DESE. One of the things that we did learn that I didn't mention about the maps before is that we're seeing some of those high needs districts as we've defined them. 35% of those districts are not receiving DESE grants. And so what's interesting about that is that those districts likely have services that they're providing and professional development that they're accessing, but they are having to kind of reach out and find it in their own way, or they have other partnerships that with community mental health agencies that are not depicted on these maps. But one of the things that we see is that oftentimes we're seeing districts where directors of SEL, social and emotional learning, or directors of mental health positions are popping up. And in those districts, oftentimes it works really well if you have that position and you have a really cohesive, coordinated district leadership team with a priority, kind of a stated priority in the area of behavioral health for kids, because then they've got this position set aside to really focus on coordinated service delivery as well as access to professional development for their service providers. Whereas some districts, the behavioral health work, or the prevention-oriented work related to behavioral health, falls on the shoulders of directors of curriculum and instruction, which creates a very large job for them, because they're thinking about academics and they're thinking about behavioral health, and they're trying to figure out how to coordinate it all. So sometimes I would say that some of those directors of curriculum instruction are spread a bit thin, trying to make all of these different pieces come together.
But you could probably also say that about many of our superintendents.
Yes.
It's a lot to put together.
Yeah.
What we noticed is that there are areas in the rural part of the state where there's less access, and there's also urban areas, gateway cities, where we're seeing less access. And both of these areas have unique situations to navigate, and the number of resources in the community to help support students. In our gateway cities, what we see is densely populated, diverse communities that have unique needs. And in Western Mass, we see more rural poverty areas where there's a paucity of community-based agencies and support services. And both of these leave our schools carrying a unique burden to support all of their students. The conversations also highlighted the role of our educational collaboratives. As Sarah was talking about a while ago, we see that our collaboratives consolidate resources to meet some of the needs of our low incident student populations. They also can provide professional development and learning. However, we saw great variability across the services that are available by our collaboratives. Most of them, primarily in the area of behavioral health, only provide professional development, and some do provide therapeutic placements. But this lack of consistency in the services and in the way that these are approached reflects the locally driven mantra that exists in our state. And there's also minimal state guidelines on how to organize these services. That results in what you see in the maps with geographic and regional disconnections in these support services for our school systems, our school personnel and kids. So what does this lead us to in conclusion? Our state, particularly in our Department of Education, is perpetuating an inequitable and fragmented system. There are disjointed efforts to address behavioral health. These initiatives have, some of them have money and training, but the lack of consistency leaves school districts lost in the language of acronyms, trying to figure out how to coordinate the services across the needs of the students in the schools, as well as across with community agencies and the Department of Mental Health. We have schools that are regionally organized that are trying to meet these needs, but we see such great inconsistencies, and some communities do not even participate. As we mentioned, a third of the schools with some of the greatest inequities do not participate in collaboratives. What this leaves us with is 406 LEA administrators lacking a universal and integrated framework and looking for ways to support partnerships and uncertainty in how to deploy staff. This conclusion is noteworthy in that a recent report from the Institute of Education Sciences indicated that districts most frequently look to their state department to provide guidance on evidence-based practices and strategies for implementation. And the fragmentations that they're presented with in our department are lacking that kind of structure. So we have some clear recommendations on how to move this forward. One of the recommendations is that the Department of Education elementary and secondary education facilitate consistent and coordinated services. So there's a cohesive conceptualization of how multi-tiered supports are available to kids with a focus on prevention and health promotion. That the Department of Education support our districts as they create school mental health plans as a roadmap on how to organize their resources, how to promote prevention, how to do early intervention for our kids as they start demonstrating some challenges, and community partnerships, outline how to develop community partnerships so that they can more effectively meet the needs of our most vulnerable students. And this also requires that we prioritize resources to the high need districts that have the most inequitable access to these school-based providers. Other recommendations focus on workforce development. It is clear that we have a lack of licensed professionals that can work in schools, and we operate from the foundational belief that kids deserve access to properly licensed and credentialed personnel. So to meet some of this need, we have recommendations around pre-service training with things like tuition waivers. We also have recommendations around professional development for our administrators, our educators, and our staff. And we also recognize that in these labor shortages that do exist in these fields across our country, that we can also have targeted efforts to bring in more diverse personnel to support the needs of our multilingual and multicultural student population. We also want to recognize that schools cannot do this alone. Partnerships are needed to assist students and families and staff as we provide the best access to services to our students. And so there is a great need for support around partnerships, for coordination of school-based services, and we also need guidance from the state on how to do blended funding. Many of our the districts that we identified with inequitable access also have many resources to support behavioral health through public systems, but those public systems funding can be blended to support kids where they are in their schools and in their communities. We also need a major adjustment and investment in our collaboratives. The lack of access to collaboratives leaves many districts trying to figure this out on their own, as opposed to having some regional structures and supports as they can consolidate resources to support students. We also believe that there's a need for a statewide technical assistance center. Access to information on best practices, information on evidence-based programs, on the promotion of culturally linguistically relevant practices are need, and we need uniformity and equity across our districts, which can happen with access through a statewide assistance center. With that, again, we ask for your feedback and ask that you join our website. There's a subscription list to also get newsletters and further information from us as we continue this work. And we want to thank you for your time and attention during this